One. Please start. We are live.
Yeah. A very good evening and a warm welcome to all the distinguished and the esteemed guests. At the outset, thank you for your gracious presence in the scientific endeavor BemTalk, a virtual platform to unlock the scientific aspects of Bempedoic acid. Dr. V at Zydus are truly dedicated to life in all dimensions. Today, Zydus is the fifth largest pharmaceutical company in India and aiming to serve the society, nation, and the whole world with the innovative, quality, efficacious, and the affordable drugs. In our quest to unite against dyslipidemia, a new hope arises after 20 years, and that's none other than a bempedoic acid. Having said that, I would like to invite our esteemed speaker for today's BAM talk, Dr. Shilanjan Roy, to set the ball rolling for today's BAM talk. About Dr. Shilanjan Roy, of course, I mean, he does not require any introduction, but there is a small introduction which I would like to make in front of the delegates. Dr. Shilanjan Roy, he is the honorable gold medalist, MD Medicine gold medalist, MRCP UK P2, and he is a DM cardiologist. He is a visiting consultant intervention cardiologist, Charnak Hospital, ILS Hospital, and the North City Hospital, Kolkata. He is the ex-senior president, Department of Cardiology, RG Medical College. He is the institutional topper in DM cardio exam. He is awarded ICAM Gold Medal for Academic Excellence in the MD Medicine University Examination. He has been awarded with the Governor Silver Medal, and he has been awarded the multiple gold medals and the university honors in MBBS professor exams. He has passed MRCP UK Part 2, and he is a zonal mentor for the National Hypertension Working Group. He is a member of numerous international as well as national societies. To name few, it's ESC, CSI, and so on and so forth. So we are really today going to get benefited with the talk which he's going to give it to us on the bempedoic acid. Doctor, over to you. Thank you.
Yes, thank you very much, Madam Pallavi, for your kind introduction. And without any further delay, we'll be starting today's session. Can you please unshare your screen so that I can share my slides?
Just one moment. Yeah, is it unshared now?
Yes, can you please share your screen?
Yeah.
Yes.
Yeah.
I think now it's visible.
Yes.
So
yeah, it is visible.
Yes. So a very good evening to all the delegates who are present in today's BEM talk, and thank you for the organizers for inviting me, Zydus. We are all excited about the launch of this new molecule bempedoic acid in Indian market, and primarily to be used in uncontrolled LDL cholesterol lowering. The concept is unlocking this novel concept of LDL lowering and unleashing the efficacy that this molecule offers in further lowering LDL cholesterol in adjunct to statin therapy. Now, as you all know, that dyslipidemia has always been a major concern for cardiovascular event, irrespective of whether it is a primary or secondary prevention. Right, starting from the Interheart study, where the 9 factors which are attributable for almost 90% of all the acute myocardial infarction, dyslipidemia or increased cholesterol levels, primarily LDL cholesterol, was seen as the most strongest risk factor, that is as far as population attributable risk is concerned, for causing myocardial infarction. Now, if you look at the cardiovascular primary prevention trials, statins has been the drug of choice historically. There are multiple landmark trials with statin, right, starting from the AFCAP, STEXCAP trial, the ALHAT lipid lowering therapy trial, ASCOT LLA trial, the CARDS trial, MEGA PROSPER trial, the Jupiter trial, where statins has been used, atorvastatin or rosuvastatin, which has been used and has consistently shown to reduce the risk of myocardial infarction, unstable angina, and sudden cardiac death. So it has been established that in primary prevention setting, statins are the agents of choice in reducing the cardiovascular risk. Now, regarding the secondary prevention trials, that is after the patient has developed an atherosclerotic cardiovascular event, MI, stroke, or an acute coronary syndrome, various trials trying different statins, be it simvastatin, pravastatin, atorvastatin, primarily the recent trials, the lipid care miracle trial, the cards trial, TNT and the ideal trial, all have studied high intensity statin therapy, and uniformly all the trials have shown significant relative risk reduction in development of future cardiovascular event. So statins have established itself as a primary lipid lowering therapy in both primary prevention subset as well as in secondary prevention trials in the cardiovascular scenario. So management of dyslipidemia is at most on priority in reducing the events of cardiovascular diseases, and statins are the first line therapy. But the problem lies is that the first concern is that do all the statin users achieve the LDL goal as per guideline recommendations? That's a big question. And as the guideline recommendations are changing day by day, year by year, the target LDL cholesterol is getting lowered. Possibly only statin may not be sufficient enough for majority of the patient to achieve the LDL goals as per the guideline. And the second point of concern is how to achieve LDL target after maximal tolerated dose of statin, because we have got very limited options after statin therapy, apart from the injectables which are extremely costly, the PCSK9 inhibitors, very limited options available which over and above statin therapy can further reduce LDL cholesterol to the guideline recommendations. So the first question, that is whether all the statin achievers LDL cholesterol achieve the LDL cholesterol goal as per guideline. That, as we all know that regarding LDL, lower is better and lower for longer time is better, which has been uniformly seen in all the statin trials, that there is almost a linear relation between lowering of LDL cholesterol and reduction in the cardiovascular risk factor. There is nearly 23% relative risk reduction with 1 millimole, that is 38 milligram per deciliter reduction in the LDL cholesterol level. And it is uniformly true even for very low levels of LDL cholesterol, as it has been seen with PCSK9 inhibitor trials like the Odyssey outcomes or the Fourier trial, where we further lower the LDL cholesterol even below 50, there is a further reduction in the cardiovascular risk, which has been seen. Now, comparison of LDL target with ESC 2016 versus ESC 2019, if we compare, there has been a stark difference and changing goalpost as far as LDL targets are concerned in the various risk category of the patients. In low risk category, if you see in 2016, the target was 115, which has remained unchanged in 2019 guideline. But from moderate risk onwards, the target has progressively reduced in the newer guideline. From 115 now in moderate risk category, it has become less than 100. In high risk, from less than 100, it is now less than 70. And in very high risk group category, which in fact encompasses all the patients who have suffered an atherosclerotic cardiovascular events or established ASCVD, or in diabetic patients with very high vascular risk, where the previous target was less than 70, but now the 2019 ESC guideline proposes the LDL target of less than 55. The LI recommendation, the Lipid Association of India recommendation, is also to achieve an LDL target of less than 50, preferably in this very high risk group patient. And LI has also proposed another classification of extreme high risk, that is patient who has experienced multiple vascular events within last 1 to 2 years. I mean more than 2 vascular events, more than or equal to 2 vascular events, where the proposed LDL target has been less than 30. So as we go on in the hierarchy of increased cardiovascular risk, the targets of LDL is gradually declining with the newer guidelines. So there is a need to further incremental reduction of LDL cholesterol. Now, there is a very interesting study, the Da Vinci study, which is a European Union-wide cross-sectional observation study on lipid modifying therapy in both secondary and primary care, which has studied the patients who are receiving on statin therapy and the patterns of statin therapy in patients of primary and secondary prevention, and how this 2019 guideline has impacted on the percentage of the patients who are achieving the LDL cholesterol goal with statin therapy. So the objective was mainly to evaluate the impact of this new guideline, 2019 dyslipidemia guideline management on the LDL goal achievement, and how this changing targets or this changing goalpost has also declined the number of patients who have achieved that newer target LDL level with statin therapy. So the primary prevention and secondary prevention arm almost comprised of similar number of participants, and it was very interesting to see that in the subsets, in all patient subset, as per the revised guideline from the ESC 2019, if you see that the proportion of the patients who are receiving, who are achieving goal with overall achievement of LDL goal was 54% as per 2016 guideline targets. The percentage has drastically reduced to only 33% with this new 2019 guidelines. Because the LDL target goal has reduced, lesser percentage of the patient on statin therapy or maybe on other non-statin therapy for lipid reduction is achieving the desired lipid goal with the statin therapy. The same holds true for other classes of agent, the patients even who are on PCSK9 inhibitor or with statin ezetimibe combination, as we can see from this blue rows, that the percentage of the patients as achieving LDL goals with statin ezetimibe combination is only 37% in comparison to 58% if you consider the recent 2019 guideline targets. The same holds true for very high risk group targets, very high risk ASCVD, which is a area of concern for all the cardiologists to reduce the risk of future cardiovascular events or recurrent vascular events. If you see that in very high risk subsets, patients who are achieving the LDL target goals with high intensity statin, the red bar was 45% if you consider the 2016 guideline. The same percentage, with the same dose of statin, the percentage of the patients achieving the target LDL of less than 50 has drastically declined to only 22%, because a significant proportion of the patient cannot achieve the target cholesterol goal of LDL less than 50 with the same dose of statin, high intensity statin monotherapy. Even in the patients who are receiving statin ezetimibe combination, the percentage of patients receiving achieving the LDL target is abysmally low, it's only 21%. The same holds true even for a very small percentage of the patients who are receiving PCSK9 also. So only 37.8% eligible patients are receiving high intensity statin. So there is a huge unmet need also in the patients receiving statin, and more so the patients who are receiving high intensity statin, only 18% of those are achieving the lipid goal with the high intensity statin. So there is a big gap between the target guideline recommendation of LDL and in reality the percentage of the patients who are achieving that target with the available statin monotherapy, even with a high intensity statin therapy. And the fallacy with statin therapy is that if you see that a patient is receiving high intensity statin therapy, suppose a patient is receiving atorvastatin 40 or rosuvastatin 20, which by definition is a high intensity statin therapy, and patient is not achieving the LDL cholesterol goal, and you just double the dose of high intensity statin to maybe atorvastatin 80 or rosuvastatin 40, which is the highest tolerable or highest acceptable levels of statin, permissible statin levels. Even then, doubling the dose of high intensity statin therapy hardly reduces LDL cholesterol by only 6 to 8%. So the further incremental reduction in LDL is very limited, even if we double the dose of high intensity statin. And it is a fact that we all know that even after statin therapy, though there is a significant reduction in the relative risk of development of cardiovascular events, but still there is a huge amount of cardiovascular residual risk that is remaining in the tune of 60 to 70%, which cannot be addressed by statin monotherapy alone. And even with the statin and ezetimibe combination, or very small percentage of the patient who can afford or accept an injectable therapy like PCSK9, there is a still significant residual risk that is remaining. So management of dyslipidemia is at most priority in the patients who have experienced an ASCVD or who are at high risk of development of atherosclerotic cardiovascular disease, and statins are the cornerstone in the treatment of these patients. But the problem is that how to achieve the LDLC target after maximum tolerated dose of statin, because the option of PCSK9 is extremely limited in our country because of primarily injectable formulation and its prohibitive cost. So the benefit of PCSK9 cannot be extended to the majority of the population in our country that are falling in this category, who are not achieving their LDL target even with a maximal tolerated dose of statin. Now, this is a very simple algorithm that has been proposed in the ESC guideline only, that an approximate average LDL reduction that can be achieved by the different dose of statin and non-statin therapies. And it's almost an arithmetic calculation. We can see that high intensity statin, as by definition we know, that can lower LDL cholesterol by 50%. High intensity statin plus ezetimibe up to 65% LDL lowering. Only PCSK9 60%, and PCSK9 with high intensity statin can reduce the LDL cholesterol by nearly 75%. So in high risk patient, though, we almost can reach the LDL targets in almost all the patients with PCSK9 and high intensity statin, but the option of PCSK9 itself is extremely limited because of the limitations or shortcomings of PCSK9 that already I have told. Here comes the role of bempedoic acid, which is a novel molecule, which is an ATP citrate lyase inhibitor, an upstream inhibitor of the HMG-CoA reductase, or acts upstream to the pathway where statin acts, a first-in-class molecule LDL lowering drug. Now, it is approved already in US, European Union, and India. In 2020 only, it has been approved in US and European Union, and the approved indication in USA and Europe has been first to reduce uncontrolled LDLc in the patients who have uncontrolled LDL even with a maximal tolerated statin dose, in patients having mixed dyslipidemia, familial hypercholesterolemia, and high risk of ASCVD patients. And the second group were the patients who are statin intolerant or in whom statin is contraindicated due to various reasons. So these two categories, bempedoic acid has received the recommendation for use. That is, for LDL lowering in the patients not achieving LDL targets even with a maximal tolerated dose, or in statin intolerant patient. The same holds true for DCGI also. DCGI in India has also given the indications of bempedoic acid for the same two indications, and the dose is 180 milligram once a day orally with or without food. Now, this is the basic mechanism of action of bempedoic acid. It is a prodrug, and the bempedoic acid is converted to bempedoyl coenzyme A, which is the active form of the drug, and it inhibits this pathway of lipid synthesis of LDL receptor, cholesterol synthesis within the liver. It inhibits ATP citrate lyase within the hepatocytes. Thereby, it acts as an upstream inhibitor in the pathway where the statins act. So it acts in before the HMG-CoA reductase inhibitors like statin, thereby it reduces the cholesterol synthesis within the liver, which in turn results in LDL receptor upregulation within the hepatocytes, and thereby causes further LDLC reduction within the blood. And by other mechanism in skeletal muscles also, by inhibiting the ATP citrate lyase, it reduces the the free fatty acid release from the skeletal muscle cells. Now, management of the patients receiving bempedoic acid therapy, few points that has to be kept in mind while we are prescribing bempedoic acid, because in shortly already it has been made available, and shortly it's going to get its momentum of usage in our clinical practice. So few points of caution that needs to be kept in mind while we are prescribing bempedoic acid with or without statin therapy in our dyslipidemic patient. First thing is that it's a once daily dosing, because having a long half-life of 21 hours, elimination is 70% is excreted through the kidney and 5% excretion is through feces. Less than 2% of the drug is excreted unchanged to the kidney. Now, in renal impairment, in mild to moderate renal impairment, no dose adjustment is necessary. However, the drug has not been studied in stage 5 CKD or in EGFR. So better not to use the drug in CKD patients or patients who are on maintenance hemodialysis. In hepatic impairment also, in mild to moderate hepatic impairment, no dose adjustment is necessary, unlike to that of statin, where we already always exercise a caution, or we are skeptical in using statin therapy. It is relatively safe in patients having mild to moderate hepatic impairment. However, in severe hepatic impairment of childbirth class 3, it's not studied. In patients, another very important point to be kept in mind, that it's possibly only indication or warning is it has got a tendency, this molecule, to increase the serum uric acid level. So in all patients who are on bempedoic acid therapy, it is prudent to assess the serum uric acid at baseline and time to time when it is clinically indicated. And patients who have a prior history of acute gouty arthritis, increased vigilance for rising uric acid or gout to be kept in mind. Also, in patients more than 60 years of age who are concomitantly taking corticosteroids or fluoroquinolones with some degree of renal dysfunction with a history of tendon rupture, patients should be warned of potential for, or rather physicians should be cautious regarding the potential for tendon rupture with this molecule when they are concomitant, the patient is taking steroids or fluoroquinolones, and advise patients to take rest at in the first sign of tendinitis or tendon ruptures appears. So the red flag signs are patients more than 60 years, the same category of the patient with a history of steroid intake or fluoroquinolones concomitantly with some degree of renal failure, with a history of tendon rupture, the molecule should be discontinued if tendon ruptures occurs, or consider discontinuing the molecule if there is a joint pain, swelling, or joint inflammation in this patient. Also, better avoid concomitant use of bempedoic acid with a high dose simvastatin more than 20 or pravastatin more than 40 milligram. Consider lowering the dose of statin or switching to a other statin like atorvastatin or rosuvastatin, because that high dose of statin has not been simva or prava has not been studied with bempedoic acid. This is not, holds very good in our country, because simva or atorva, this prava, this high dose is not available in India. We are not using it. In pregnancy, better to discontinue bempedoic acid unless the benefits far outweighs the risk, and in breastfeeding it is not recommended. So these 3-4 points of caution, that is patients with pre-existing, prior history of gout, hyperuricemia, close monitoring of uric acid level, in patients having some degrees of CKD, receiving concomitant corticosteroids or fluoroquinolones, already at the risk of tendinitis or tendon rupture, concomitant use should be avoided. Now, let us look at the studies that have prompted the guideline authorities to give bempedoic acid this recommendation of usage in addition to statin therapy or in statin intolerant patient. Now, bempedoic acid studies, the CLEAR group of studies has been a very exciting phase 3 program where 2 definite classes of study has been done. One is in the patients who are patients of atherosclerotic cardiovascular disease, or patients of heterozygous familial hypercholesterolemia, or both, where patients were already on statin, maximally tolerated dose of statin, not achieving the target LDL cholesterol goal, that is patients of ASCVD with LDL of more than 170, or patients of heterozygous hypercholesterolemia with an LDL of more than 100, not achieving, receiving high intensity statin or maximally tolerated dose of statin, but still the target is not reached. These 2 patient population were studied in CLEAR Harmony and CLEAR Wisdom trials. Almost the study pattern was similar. Most of the patients, as you can see, were having ASCVD, a smaller percentage of the patient having heterozygous hypercholesterolemia. Another group of CLEAR program was CLEAR Serenity and the CLEAR Tranquility program, which studied patients not having established atherosclerotic cardiovascular disease, but primarily high risk of ASCVD, primarily or in the primary prevention subset who are statin intolerant. Some patients were having prior ASCVD, but a major part was in primary prevention also. But this group of patients were either or very low dose of statin, low or very low dose of statin, or no statin at all in the background therapy, primarily because they are statin intolerant or had serious adverse events with higher doses of statin. So these were 2 different classes of studies: the CLEAR Harmony Wisdom in established ASCVD already on high intensity statin, and the Serenity and Tranquility patients on very low dose of statin or either on no statin, because these patients were primarily statin intolerant. Now, in Harmony and Wisdom, CLEAR Harmony Wisdom, the type of patients, as we have seen, ASCVD, heterozygous familial hypercholesterolemia, both either they are on maximally tolerated or on other background lipid lowering therapy. 52 weeks was the duration of the study. All this study population were on statin therapy. The efficacy endpoint was percentage of LDL cholesterol reduction from baseline at 12 weeks, and the safety endpoint was studied at 52 weeks. So it was seen that in both in clear harmony and clear wisdom, persistent hypercholesterolemia was there despite maximally tolerated statin therapy, and after bempedoic acid addition there has been a significant reduction in the level of LDL cholesterol on top of placebo in both the studies. In clear tranquility, as you can see, the baseline LDL cholesterol reduction was statistically significant in both these studies. I'll come into the details. In another study group, that is in a statin intolerant patient, which was studied in the clear tranquility and clear serenity, patients with hypercholesterolemia and statin intolerance, where in tranquility bempedoic acid was added to ezetimibe, that is none of the patients were in statin therapy, and in serenity trial it was primarily bempedoic acid therapy. Some percentage of the patients were, as I have already told, was either on low or very low intensity statin. None of them were on moderate intensity or high intensity statin therapy. And in clear serenity, the percentage of statin percentage of patients receiving some dose of statin was even lower. The efficacy endpoint was similar, that is percentage LDL reduction at 12 weeks, and overall safety endpoint was studied at 12 or 24 weeks. And it was seen that in these two studies also, the patient who received bempedoic acid, who could not tolerate statin therapy, there was a significant reduction in LDL cholesterol in comparison to the placebo arm in only bempedoic acid therapy or in the patients who received bempedoic acid with ezetimibe. So alone, bempedoic acid or ezetimibe alone or in fixed dose combination with placebo, in both these arms, there was a significant reduction in LDL cholesterol, and the reduction in LDL cholesterol was incremental when these two classes of agents were added. Now, another important point, these two trials, group of trials, that is a clear wisdom and the clear harmony trial, though it primarily studied the established atherosclerotic cardiovascular disease patient, high risk patient already on maximally tolerated statin therapy, none of these trials were outcome trials. That is, they did not study the primary efficacy endpoint was only lowering of the LDL cholesterol, and how far this lowering of the LDL cholesterol translates into event reduction or reduction of the 3-point or 4-point major adverse MACE reduction, that was not studied in these trials. So the outcome trial with bempedoic acid is being studied in the clear outcomes global cardiovascular trial, which is a large trial enrolling nearly 14,000 patients. The trial enrollment is complete and the tentative study completion date will be by this year, December. This is a very beautifully designed study in where both primary and secondary prevention patients with elevated LDL cholesterol and statin intolerance has been randomized to bempedoic acid versus placebo, and after a single blind placebo run-in period, double blind treatment period evaluating MACE and LDLc reduction as well as safety of bempedoic acid therapy. And in this study, the outcomes of 4-point MACE, that is CV death, non-fatal MI, non-fatal stroke, and coronary revascularization events in the patients receiving bempedoic acid therapy will be studied. And by the end of this year, it is expected that we'll get the results of this clear outcome study. In ADA 2022 also, in addition to the guidelines, they have mentioned bempedoic acid as lipid lowering agent in high risk patient. Now, if we go to the pooled analysis of the phase 4 of phase 3 pivotal trials, adverse events of special interest first was as only event that showed statistically numerically higher values than the placebo was incidence of hyperuricemia and gout. So these two are factors which should be closely monitored in the patients who are receiving bempedoic acid therapy, and possibly patients who had a prior history of gout or acute tendon rupture is a relative contraindication to initiate bempedoic acid therapy. Increase in SGPT and SGOT more than 3 times upper limits of the normal, which is a common problem with high intensity statin therapy, has not been seen with bempedoic acid, which is a, big benefit of initiating or big plus point of starting this therapy. That is, there is no indications of any liver dysfunction. Tendon rupture, though it has been seen, it has not been shown to be statistically significant, and there has been no signs of new onset or any worsening diabetes mellitus, which is also a contentious issue with use of high intensity statin therapy. So in summary, if you can conclude, few slides I think has been missed, the outcome. I'll just briefly discuss that in clear harmony, clear wisdom, couple of the slides they are lacking. One is that the LDL cholesterol lowering in bempedoic acid arm, it was nearly 17 to 18% reduction in the LDL cholesterol, as well as there was 18 to 20% reduction in the total cholesterol level, and reduction in the apolipoprotein A also, which is also a very important marker of the residual risk. Next, another important point that was seen with bempedoic acid therapy, that reduction in the HSCRP, high sensitivity CRP, that is a marker of vascular inflammation, that is also statistically significantly reduced in patients who received bempedoic acid therapy, and that was seen in both clear harmony wisdom, that is in the when it was used in combination with maximally tolerated statin dose, as well in the patients of primary prevention in the statin intolerant patient, the reduction of HSCRP was statistically significant. And this is a very exciting indication that, like that of statin, where the lowering of HSCRP, which is a marker of vascular inflammation, has been attributed as one of the factors resulting in other pleiotropic effect of statin, that effect of reduction of inflammation or vascular, HSCRP or vascular inflammation, is also being seen with bempedoic acid. So it's not only lowering of LDL cholesterol, but also lowering of other parameters of total cholesterol, lipoprotein A, and also reduction of HSCRP that has been seen with all these phase 3 clinical trials. So in summary, we can tell that uncontrolled LDLc is a major risk factor for CVD. Statin is still the first choice for any type of dyslipidemia, and even after high intensity statin therapy, a large proportion of the patient have uncontrolled LDL cholesterol levels, and it increases the residual CVDs by 60 to 70%. So there is a huge gap and unmet need where there is a scope for novel LDL lowering agents or novel lipid lowering agents to address this residual cardiovascular risk. And bempedoic acid is first in class agent having this unique mechanism of action of ATP citrate lyase inhibitor, and there has been a significant LDL reduction of up to 18% from the baseline, even as an adjuvant to statin. And when it is used as a single agent, there has been a reduction of LDL cholesterol up to the tune of 25 to 28%, either as an monotherapy, bempedoic or bempedoic acid with ezetimibe. And it is safe in mild to moderate CKD patient, even in patients with mild to moderate hepatic dysfunction. No safety concerns regarding new onset diabetes mellitus or any rise in liver enzymes, though hyperuricemia gout has been shown to be a common adverse event which should be monitored on a regular basis. Otherwise, more or less, it has been shown to be a very safe drug when even in the long term of 52 weeks of follow-up. So that's all about this new molecule, and hope we'll be using shortly this molecule in our clinical practice and see how the drug fares in Indian population also. Thank you.
Thank you so much, sir. It was really very, very scientific and to the point presentation. So thank you so much, sir. Sir, looking at the new molecule, and there is a lot of newer things which are there associated with this molecule. So there are doctors who have actually asked many questions. So with your kind permission, sir, may I ask you those questions?
Please go on. Please.
Yeah.
Sure.
So, sir, Dr. Joshi, he is based at Mumbai. He's asking, according to you, how low is very low with respect to the LDL levels?
The answer to this question is we have already got this answer after we have received the trial results of the PCSK9 inhibitors, that is Fourier and Odyssey, which have shown that even at a very low LDL cholesterol of less than 30, we get incremental benefit of LDL lowering, that is further reduction of cardiovascular risk, even if we go LDL of below 30, even below 20 or up to 15, which can be achieved with, has been achieved with PCSK9 inhibitor. So we cannot tell that a particular level of LDL cholesterol is too low, and it's a common notion that possibly lower is better, that as low if you can go, because there is no significant safety concerns of lowering LDL cholesterol even to a very significant low level of less than 30 or even less than 20. So if you can go to a low level of cholesterol, particularly in the patients who are at high risk of developing cardiovascular events or who have experienced a previous atherosclerotic cardiovascular event or a history of recurrent vascular event, we should aim for a very low LDL cholesterol levels as far as possible with the highest intensity statin therapy and other non-statin molecules that we have. And as far as guideline recommendation, at least an LDL cholesterol level of 50 should be achieved in patient of very high risk, high CV risk, and in patients who are having extreme high risk, as already the category been proposed by Lipid Association of India, that is patient experiencing recurrent vascular events or patients having ASCVD with familial hypercholesterolemia, LDL of less than 30 can be targeted for. I cannot hear you, madam.
Yeah, actually, I was not able to unmute.
Okay, okay.
Yeah. So now the second question is, sir, if patient cannot tolerate minimum dose of statin, will bempedoic acid will help to reduce the additional LDL level? This is Dr. Ghosh, based at Barakpur.
Yes, absolutely. It is one of the indications of bempedoic acid that, as we have seen, I have discussed the clear serenity and the clear tranquility trial. This particular subsets of the patient has been tried, with bempedoic acid therapy. The patients who are absolutely statin intolerant, you cannot start any statin in this patient. In this study group, at least 2 classes of statin has been tried, and only after the patient has been shown to be intolerant to even 2 classes of statin therapy, even in a very low dose, moderate, even they cannot tolerate a moderate dose of statin therapy, only then bempedoic acid has been given as an alternative lipid lowering agent. And bempedoic acid have fared excellently in the subsets of up to LDLC reduction of up to 28%, which has been shown in clear serenity and in clear tranquility, where it has been tried with bempedoic acid with ezetimibe, and the lowering is even incremental. So the patients who are not tolerating statin therapy with 2 classes of statin, even at a lower doses of statin, you can start bempedoic acid as a monotherapy or bempedoic acid with ezetimibe in these classes of agent for lowering of LDL cholesterol or achieving the LDL cholesterol goals.
Thank you, sir. So the next question here is, how suitable will be BAMDAC for Indian population when statin is the first choice for Indian dyslipidemia? This is Dr. Shetty, based at Mumbai.
Yes, very good question. For Indian patients, I think bempedoic acid is going to be a very exciting choice. Firstly, because it has got some novel benefits over and above statin, and some are, additional to that of statin. First is that, as we have seen, that in Indian patient, the incidence of statin-induced myopathy is pretty common, and bempedoic acid, particularly, it has shown that it has not any signs of increasing the myopathy or any risk of myopathy or muscle pain in the patients who are receiving bempedoic acid. So in patients who are not tolerating high intensity statin because of myopathy, muscle pain, or other muscle related problems, rise in CPK, in this patient you can start with a moderate intensity or a lower intensity statin and add on with a bempedoic acid to achieve the target LDL cholesterol goal, because you might be unable to achieve the target LDL cholesterol with high intensity statin because the patient is not tolerating statin at all. So that is one benefit in Indian patient. Secondly, benefit is that Indian patient, as we all know, they're at high risk of vascular inflammation, and most of them are suffering from metabolic syndrome, insulin resistance. So because bempedoic acid has, apart from statin, the first in class hypolipidemic agent which has shown reduction in this hsCRP, which is also a surrogate marker of inflammation and vascular progression of vascular disease and vascular inflammation, it might show an incremental benefit in reduction of prevention of endothelial dysfunction and progression of atherosclerotic cardiovascular disease, which is one of the pleiotropic benefits of statin that can also be translated with, seen with the use of bempedoic acid also. So, thirdly, many patients where they are showing signs of new onset diabetes or rising, dysglycemia, with the use of high intensity statin therapy. In these subsets of the patient also, because bempedoic acid has no signs of causing a new onset diabetes, you can try bempedoic acid in that subset also with a low or moderate intensity statin to achieve the LDL cholesterol goals. So these are the subsets which are going to benefit particularly in the Indian patients or Indian subcontinent.
Thank you, sir. So the next question here is, can it be given with PCSK9 inhibitor, and what should be the expected results? Dr. Mehta, based at Ahmedabad.
Yes, it has been tried with PCSK9 because in the clear harmony trials, the first group of trials where the patients were receiving ASCVD, already established atherosclerotic cardiovascular disease, already on highest intensity statin therapy, though a small proportion of the patients were on PCSK9, but it has been tried, bempedoic acid has been given, and it had shown further incremental lowering of the LDL cholesterol. Though large data is awaited, and with PCSK9, the fact is that, most of the patients who will be receiving PCSK9 are expected to achieve their LDL target goal with PCSK9 only or with PCSK9 and statin. So very small proportion of the patients will be eligible candidates for bempedoic acid, because bempedoic acid is still a molecule which has to be used in combination with a statin or only in statin intolerant patient. It should not be used in a patient as a monotherapy with PCSK9 in patients who can tolerate statin therapy. So only bempedoic acid with PCSK9, we don't have much data, but in absolutely statin intolerant patient, if the patient is receiving PCSK9, still not achieving the goal, it might be tried.
Sure, sir. The next question is, can it be given with ezetimibe without initiating statins?
Yes,
this is Dr. Muchala, based
yes,
at Ahmedabad.
Yes, absolutely. In patients, the same thing, that all these populations has been studied in clear tranquility trial, as I have discussed, that in patients who are not receiving, who are either extremely statin intolerant, no statin can be started in even in lower doses whatsoever, or they are in very low doses of statin. In these subsets of the patient, bempedoic acid has been started with ezetimibe combination without statin therapy, and this combination has shown to reduce LDL cholesterol up to the tune of 28%, which is almost equivalent to a moderate intensity statin therapy. So definitely in patients who are absolutely statin intolerant or who have a contraindication, definite contraindication for statin usage, this patient can be started with bempedoic acid and ezetimibe combination for incremental LDL lowering.
Sure, sir. Sir, next question is, in patients with high LDL who are intolerant to statin, what should be your treatment approach? Dr. Biswajit, based at Sriram.
Please repeat the question once, madam, again.
Yeah. So the question here is, sir, in patients with high LDL who are intolerant to statin, what should be our treatment approach?
Yes, very good question. It's a very practically oriented question. Patients who are statin intolerant cannot, who is a candidate for high intensity statin therapy, and where the LDL treatment goal is less than 50, I suppose, in the patients who have established atherosclerotic cardiovascular disease, but cannot, tolerate high intensity statin. The first choice the option that we have in our hand is ezetimibe and bempedoic acid among the non-injectable therapies. So these two molecules, either it can be added with a low intensity statin therapy, low dose statin therapy, low dose statin with an ezetimibe, or low dose statin with the bempedoic acid, we can see the response, that how the patient fares, whether we can achieve the LDL cholesterol goal with that. If the patient is not achieving LDL goal with this combination of low intensity statin with the bempedoic acid or low intensity statin with an ezetimibe, we can give all these three, that is low intensity statin, bempedoic acid, and ezetimibe together to achieve the target goal. And in selected patient with very high risk of CV events or extreme high risk group or patient experiencing recurrent vascular events, the option of PCSK9 inhibitor with bempedoic acid should or ezetimibe should definitely be discussed with the patient.
Sir, the next question is, if we have prescribed bempedoic acid in hyperuricemic patient, how frequently should we monitor uric acid level? This question is by Dr. Kunal Zaveri.
Yes, in patients, if we have, we are using, we have to use bempedoic acid. We don't have other option of using any other class of statin, LDL lowering agent. In patients having hyperuricemia, then 2-3 points we have to keep in mind. First is that definitely close periodic monitoring. The first monitoring should be done within a couple of weeks, and then possibly every 2 to 3 monthly, the level of uric acid should be monitored and closely monitored for any signs and symptom of acute gouty arthritis. And if the patient is developing any acute gouty arthritis, then the molecule has to be discontinued. Secondly, if we are prescribing bempedoic acid and patient's uric acid level is borderline high level, on the borderline higher side, then the other methods of reduction of uric acid, that is using xanthine oxide inhibitors like aripiprazole or febuxostat, may be tried in concomitantly with the use of bempedoic acid. Choice of antihypertensive agents, like some ARBs, as we all know, losartan has got an hypouricemic property, reduction of uric acid level. So while choosing drug like ARB, we can choose losartan, which has got a further additional benefit of lowering uric acid, that can be chosen. And reduction in the purine containing diet, reducing the protein content, the red meat content in our diet, or the seeds, legumes can reduce the uric acid level. So when we are prescribing, we don't have any option than to prescribe bempedoic acid in patients already having uric acid level on the higher side. We have to keep in mind, choose drugs accordingly which can further lower uric acid level. We have to use uric acid lowering, might have to use uric acid lowering drugs if the uric acid is increasing after introducing bempedoic acid, and strict dietary restriction which can further reduce uric acid level should be tried. And even after that, if you see that there is a significant uric acid lowering, or the patient is experiencing symptoms of gout, then we have to discontinue this class of agent.
Thank you, sir. So the last question is, what is the warning level of serum creatinine when bempedoic acid cannot be given?
It is not serum creatinine, it is EGFR level that should be monitored. So up to EGFR of 30, they have tried this molecule, and so up to CKD stage 4, that is CKD stage 3B, it can be safely used. But below that level, this molecule has not been tried. It is better to not use in the patients who are on maintenance hemodialysis or CKD stage 5, that is EGFR less than 15. Between 15 to 30, it's a no definite data is available. It's a data-free zone, you can tell. But up to EGFR of 30, this molecule can be safely used. But it has to be kept in mind that the safety points that I have told, that if the patient is concomitantly receiving corticosteroids or flunocoutinone type of drug due to some other reasons, and some grades of CKD is present, it might increase the risk of tendinitis or tendon rupture. So that thing has also to be kept in mind and monitored for.
Okay, sir, there are a couple of questions more. Actually, a lot of doctors have been asking the question. So any role in the TG reduction? Dr. Srinath has been asking.
Yes, some reduction in triglyceride level up to in the tune of 10 to 15%, which has been seen in the clear wisdom and the clear these established ASCVD trials with high intensity statin therapy, further lowering of triglyceride. But it is not very statistically significant. But in patients where statin is not able to lower the LDL cholesterol, and we are giving bempedoic acid, some benefit of reduction of triglyceride may also be seen in patients, and particularly how far it fares, how better it fares in Indian population, because in Indian atherogenic dyslipidemia with a high triglyceride level, high small dense LDL cholesterol level, it can only be told after we have gained a lot of clinical experience of using this molecule.
Okay, sir, how much bempedoic acid decrease lipoprotein little a levels in clinical trials, sir?
Lipoprotein,
Dr. Dheeraj Kumar Haldar.
lipoprotein A level has also shown to be reduced by nearly 15 to 20%. Nearly, and it was statistically significant. And the beauty was that the reduction was on top of statin therapy. Already all the patients in the Clear Wisdom and Clear Harmony trials, all the patients were in maximally tolerated dose of statin. And even on top of that high intensity statin, when the patient was started on bempedoic acid, there was still a significant reduction of lipoprotein A levels as well as HSCRP level that I had emphasized on top of high intensity statin therapy.
Yeah, Dr. Sayanti Karak, she's asking, Doctor, very good evening. My question is, if a pregnant woman suffering from dyslipidemia, what should be given in such cases?
Yes. In pregnancy, if there is a significant dyslipidemia, primarily in homozygous or heterozygous familial hypercholesterolemia, when we have to use lipid lowering agent, possibly the safest is the bile acid sequestrants, and statin should not be used in certain subsets of the patient. PCSK9 has not been tried. Also, bempedoic acid has not had its safety data in pregnancy. So the molecule which is safest is possibly bile acid sequestrant, and other classes are not much used. It is better not to use other classes of agent unless and until it is extremely necessary, which is a very small proportion of the patients where we have to use lipid lowering agents in pregnancy.
Yeah, thank you, sir. Sir, there is a last question which we will take now. As bempedoic acid reduces the new onset of diabetes or HSCRP, can it be suitable option for pre-diabetic patient? Dr. Abhijit Kumar.
Yes, it can be tried definitely, though not a molecule for preventing diabetes, but definitely in the patients who are showing signs of dysglycemia or impaired fasting glucose and impaired glucose tolerance. In these subsets of the patient where there is always a concern in our mind of introducing statin therapy, that statin might precipitate diabetes, clinical diabetes in these patients, we definitely can start with bempedoic acid therapy in these patients, particularly with a low addition with a lower or moderate intensity statin therapy. It can achieve the same LDL cholesterol lowering, albeit with a lesser risk of development of new onset diabetes.
So thank you so much on this lovely Friday evening. It was really an academic feast or the scientific feast which we all have benefited with. Sir, I would like to highlight that there are close to about 500 doctors across India have attended and benefited with this academic initiative.
Excellent.
It gives us a great honor and privilege to propose a vote of thanks to an eminent speaker, Dr. Shilanjan Roy, for his excellent deliberation. Doctor, this scientific initiative is brought to you by Zydus, who are the makers of BemTalk. Sir, BemTalk is the first time in India, sir, we have launched bempedoic acid after 20 years of a long wait with the brand name BemTalk. I'm sure that all of you, whenever you get an opportunity to prescribe BemTalk in your uncontrolled LDL cholesterol patient, please go ahead and prescribe BemTalk. Thank you so much, sir. Thanks for your nice deliberations. Thanks.
Thank you very much. Thank you.